Home of Medicine podcast with me, Dr. Amy Burbridge. I'm a consultant in acute and general medicine in the United Kingdom. And today I'm joined by...
Hi, my name is Ben Lovell. I am also a consultant in acute and general medicine working in London.
Thank you for joining me today, Ben. As ever, it is brilliant to have you on board. I am going to discuss a case.
Go for it.
So this was again quite recent, in the last few weeks. And it was early morning and I was the acute medical consultant on call. So for that, I tend to cover the medical decisions unit. However, sometimes we have lots of people in the emergency department who are unwell and need a senior review. On this particular day, there were 33 patients to see in the emergency department, which was a huge number of patients. And there was me, and I, for any will in the world, I am never going to see that many patients properly and be able to make decisions. So the reason why this was a very difficult day is I went to see the first patient. She was a 51-year-old female who had quite a significant past medical history of note. She had previous strokes in the past, which had led to a dense hemiparesis on the right side. She was actually a resident in a nursing home because of the strokes. However, she was still able to function pretty well aside from the hemiparesis. In addition to that, she had a very heavy alcohol intake and was still drinking around a bottle of vodka per day. So a huge amount. In addition to that, she had seizure activity. Now, it was never really identified whether the seizure activity was due to the previous stroke damage on the brain, or was it due to alcohol withdrawal seizures? And no, it was never very clear. It probably was a crossover of both. So I was asked to see the patient on the morning to make a decision about end of life care. And I was, okay, I need to go back to the beginning. I need to figure out, what's the picture here? Really, is that the decision that I need to make? Or do I need to think, what else do I need to be able to do physically for this patient? So as I detailed, that was her past medical history of note. She'd been admitted the night before with increased seizure activity and what looked like overwhelming sepsis, actually. We're unsure of the sepsis. Could have been aspiration pneumonia, could be urinary. She had a long-term catheter in, but she was very, very sick. And when I walked into the resuscitation department, she was very, very unwell. She was very tachycardic at 122 beats per minute. Her blood pressure systolic was 80, so pretty low. Her respiratory rate was very high. So she was fulfilling the sepsis criteria. She looked really poorly in bed. You look at the end of the bed and you think, oh, you look really poorly. And I looked through the nights of the doctor who'd seen him overnight, and they'd done everything. They had treated the sepsis, treated the seizures, you name it, everything had been done. Discussion with the intensive care unit, everything. I think that the doctor who'd seen him had done a fantastic job and literally had done everything possible. And I had a lot of staff in the A&E going, so you're going to make her end of life? You're going to, come on, somebody's got to make the decision because, she's not getting any better. She lives in a nursing home, it's what the family wants. I was like, okay, I don't know this patient. I don't know the family. I need to do a full assessment of the patient in front of me, and I need to have a conversation with the family. This is really important. I can't have a conversation with the patient because she wasn't conscious at that point. Her GCS was reduced. So I assessed the patient, and yes, she was very unwell, but I needed to speak to the family. So I contacted the family, and the response I got was, can people please stop calling me at home? I'm not married to this individual. I don't really want anything to do with the case. And I've been saying for years that she shouldn't really be living anymore. And I was like, whoa, okay. That is not the response I expected at all. And wow, it just felt overwhelming. What was best for the patient? The relative didn't seem to want to engage, and that was the next of kin who had got written on the notes. I don't really know. I didn't know what to do. What are your thoughts?
Did you say she was 53?
51.
51, so still very young. Okay. Well, a very sick, possibly terminally unwell, multi-morbid patient with sepsis. Fine. I'm intrigued by this statement. Can you make her end of life?
Oh,
What? I don't have that power, and either the patient is or isn't, and I'm not quite sure what do people mean when they say, "Can you make
I
him any?"
know. And I heard that phrase so many times that day. And
Should
it
they
was,
be establishing a certain treatment plan, or is there a document or something, or
I think, what they wanted to happen, or, was
palliation?
palliation. Was this patient's receiving the best possible care, the kindest possible care? Would
Mm.
the kindest thing and the best thing for the patient be to allow a natural, dignified death?
Uh-huh. Okay.
And at that moment in time, I assessed the patient, couldn't get hold of I spoke to a family member. They said, I'm not going to talk about it now. I'm coming in at 3 o'clock in the afternoon. It was 9 o'clock in the morning. And I said, actually, I don't have enough information here at the moment to diagnose dying. I don't feel confident and comfortable enough doing it. So I'm going to continue with the current management plan of treating the sepsis, supporting the blood pressure, giving the antibiotics, continue with catheterization, continue with active treatment, which the night team had done and I felt was appropriate. And when the family comes in later on in the day, I will have a discussion with the family and we will make a plan together. We will have an open and honest conversation about what is going on.
Okay. I think that we need a language change around palliative medicine and all this sort of
Yeah,
thing.
absolutely.
That some of the phrases that get thrown around belie a misunderstanding about the nature of palliative medicine. For example, are they for active treatment? Palliative treatment is active. I don't understand. What is it? Is it passive treatment to give them a syringe driver and painkillers? I don't understand. So active treatment, I think, is open to wildly different interpretations. I think if we were going to make more focused questions about your patient here would be what should the ceilings of treatment be for this patient? Number one, are they for invasive organ support, ventilation, vasopressors to help with the sepsis? Or are they for the ward as the ceiling of the treatment that we give, which is IV treatment, oxygen, possibly NIV if indicated, if or not? I think that's a good conversation to have, and I think that is a much more clear question than have you made them end of life? Are they for active treatment? I don't get on with those statements because they don't have much meaning for me, or rather they have too many meanings depending on who's listening to them. So I think establishing the limits of your treatment with the patient, so they're not exposed to unnecessary harms which will not work, I think is a great discussion to be had. And that of course includes if they die of sepsis or if they die as an endpoint, do we attempt cardiorespiratory resuscitation, or do we not do that? And that's part of what the treatment's on. I think those are clear questions which need to be answered within a relatively short time frame, because it sounds that she could be terminally well within the next few hours. I also think there is still a very binary thought process as therefore treatment for the sepsis or therefore palliative care. Palliative care is a very complex specialty, and part of treatment can involve giving fluids and antibiotics. That can still be part of really good treatment of someone who is at the end of their life. And I think we have to remember that palliative care for people now is responsive to the patient rather than prescriptive. You and I remember the Liverpool care pathway from, was it the early thousands?
A long time ago, yeah,
It
absolutely.
was an idea that if you or I or anyone decided the patient was dying, they were put on the LCP, which said no fluids, no antibiotics, just a cocktail of morphomidazolam anti-secretory medications. And so then, of course, death became a foretold conclusion because we withdrew everything else. And the reason why that was binned and we now have much more responsive pathways and treatment care plans in progress is that we look at the patient in front of us and say, what does this patient now to be out of pain, out of distress? What other treatments do they need? And anything can go. You can give them anything which you think will be helpful to that patient. You can even say, I've only just clocked this patient. I can't get a sense of whether they're dying or not, which is what you said, because dying can be quite slippery to diagnose, I find, even with my years of experience. I think we keep giving them the antibiotics, we keep giving them the fluids, but we can also, if they are in a lot of pain, give them a bit of morphine. If they're suffering from terrible distress or agitation, we can give them a bit of midazolam. but it doesn't mean that we are doing the livable care pathway and that's all they're going to get. And I wonder if it's a legacy of that people still find this either or thinking, this binary thinking. Like, well, I don't understand, why are you giving oxygen? I thought they were dying. We're not doing obs anymore. We don't think like that anymore. We think about, what's my patient, this human being in front of me, what do they need now? And that could be a very wide variety of treatments.
I genuinely find it the most difficult part of my job as an acute physician is diagnosing somebody who's dying. And if they are dying, is that dying going to be imminent, or is it days or weeks?
So that's what relatives want to know, don't they? They want to know,
I want to know, and that's the question I'm asked.
Should I
all
stay?
the time is,
I go, or will it be? And it's difficult to tell. We always get it wrong. I feel like
always get it wrong, and I'm just going to throw something else in the mix now, which made the day more challenging. So I went to see a 63-year-old gentleman in resus after this lady who I'd seen, and I'd decided at the time, whether right or wrong, but at the time, the right time for her was to carry on with active treatment. I needed to talk to the family. I needed to have an open and honest conversation. I needed to find out a lot more information. And they were going to come in and we're going to have this conversation. So that was okay. I moved on to patient number 2 of the day. He was in the resuscitation area. He was a 63-year-old gentleman who wasn't normally looked after in the hospital where we were at, and in fact had all of his care at a different hospital, but had come to us overnight because he had ECG changes suggestive of a STEMI. He had a background history of hepatocellular carcinoma, which was for no further chemotherapy or any further oncological treatments. And the decision had been made by the oncology team that he was for palliative treatment only from the perspective of his malignancy. He was at a local hospital and was sent over to us, as I say, with a query STEMI. But when he came, his potassium was over 8. And the ECG changes suggestive of a STEMI were actually hyperkalemia. He had a tall tented T wave. He had a low flat P wave. And he had a very broad, bizarre QRS complex, all suggestive of hyperkalemia. He was seen by the cardiology team who said, this isn't a STEMI, this is hyperkalemia, treat the hyperkalemia. So overnight, the same doctor who'd seen the other lady I'd just seen had seen this gentleman, and again set an excellent management plan in place and had treated all of his acute medical problems appropriately. So I treated the hyperkalemia. In addition to that, he got an acute kidney injury with a very high urea and a very high creatinine, and his liver function was also abnormal. So he had an INR, which was 2, he had a climbing bilirubin and a climbing alk phos and ALT, and it all sort of fits a hepatorenal syndrome type picture. And I saw him and he looked unwell, as you'd expect a gentleman with all of these things going on, but he was very chatty, sitting up in bed, looked incredibly, well, it was really interesting. And so I took a history and I examined him. He had very large, tense ascites, which was causing quite a lot of discomfort, actually. And my concern was, does he have spontaneous bacterial peritonitis as well? Do I need to be thinking about sepsis and treating that? So he had liver failure, renal failure, possible sepsis from SBP. There was a little bit of encephalopathy as well, a little bit of confusion, but was okay. And somebody asked the question, is this gentleman dying? And I was like, well, I don't know. Again, I don't know. I've 2 patients in a row, so I'd seen patient number 1, then patient number 2, and I was being asked the same questions for both cases. And again, I was asked to diagnose dying or recognise a dying patient. And I identified quite a big, maybe not a gap in my knowledge, but more like, I don't feel comfortable making this diagnosis, actually. And what I did is I spoke to the renal team, and I got the renal team to come down from a renal perspective. I got the gastro team to come down from a gastro perspective. And I spoke to the family, and his wife was, I'm on my way, but I live a long way away. We live closer to the other hospital. I don't have transport. And I said, that's okay. Don't worry about it. You're coming in at 4:00 this afternoon. I'll have a chat to you then. What are your thoughts?
Okay.
Apart from I'm not having a very good day.
Oh my God. Tell me you took a tea break after those two
You
patients.
know, I was with a really fantastic trainee doctor, and she was so lovely and so like supportive. She was like, "Would you like a coffee? Would you like a
Well,
cup of
welcome to
tea?"
acute medicine. I think also we need, they need to see us taking breaks. They know that that's something that you should do. I think there's a bit of role modeling
Yeah,
there. Like this
yeah,
was very
absolutely.
intense. Let's just take 10 seconds just to breathe it.
Oh gosh, it was so overwhelming.
But diagnosing death, so it is hard. And what I sometimes, I mean, there are clinical features. Sometimes have they got cold mottled peripheries? Are they so consciously depressed? Their airways gone, they're rattling. Sometimes that they are good clinical clues, but sometimes you just don't know. And I say so often, I can actually hear myself saying it in meetings. This patient may not die on this hospital admission, but I need a sense of a trajectory. I can't make that diagnosis based on a snapshot. So we'll admit them, and maybe when I see them on the ward round tomorrow, I'll see their trend, and I'll be able to make a clearer decision about whether or not I think they are dying. So again, it needs a bit of vitamin T, a bit of time. And sometimes when you see them the second time and you can compare them to how they were yesterday, that's when you either say they're a bit better, or they are way worse, or they're still the same. And sometimes I'll say I still need a bit more time. I can adduce other people's opinions. Like as you did, get a more of an MDT approach. And where I work, I can get a fantastic team called the Transforming End of Life Care Team, who are a subgroup of the palliative care team, and they can come and give us their expert opinion as well. And sometimes they say too early to tell, but it would not be a bad thing to prepare anticipatory medications, to warn the family that it may not have a positive outcome, to begin thinking about what's important to the patient if this is their last hours and last days. But yeah, a snapshot diagnosis of dying is I think very, very hard to do in a patient who's talking to you. I need more time. They may
Yeah,
die of submission, but I can't make that judgment call here. Let's see what they're like tomorrow, and I'll know the trajectory.
yeah, absolutely. And that is exactly what I thought. But it was so overwhelming that I was being asked to make decisions about two very similar patients who are both young. And it was just really difficult. And I went away for about 10 minutes. I think I saw somebody else because I needed time to think actually. And I also was waiting for the renal team to finish their assessment, the gastroenterological team to finish their assessment. So I went away, I saw another patient, gave me a bit of time to think. And when I went back to see patient number 2, he'd made a dramatic change. He had deteriorated so much in 30 minutes. Like it was massive. Not surprising with a potassium of 8, which we were actively treating with all the appropriate medication. I'd even done a ultrasound guided acidic tap to find out whether there was any bacterial peritonitis. You know, we were really trying to support and treat everything that was going on, but the deterioration was huge. So I phoned his wife again from the emergency department, and I said, "I'm so sorry. I know I've just called you, and I know it was only like 30, 40 minutes ago. So there's been a real deterioration and a change in your husband." And she said to me, his wife, "Is he dying? Do I need to come in now? Do I need to bring all the family in?" And I was like, I don't know. Like, and I often find that we are asked by relatives that question, are they dying? And if so, how long will it be?
Mhm.
It's almost like they want, which I get, you know, is it going to be 10 minutes? Is it going to be 10 hours? Is it going to be 10 days? Because they need to gather family, I
Mhm.
guess, to come and see. And my response was, I can't say exactly. However, he's deteriorated very, very quickly and he looks very, very unwell.
Mhm.
She said, should I come in now? And I was like, yes. Should I bring all the family? Yes. Because
Yeah.
I would rather the family be there
Of
if,
course.
you know, they're not. So they all arrived. I mean, there was about 20 members of the family who arrived. And I had a very open and honest conversation with his wife. And I said, the deterioration has been very quick. And she said, he's been suffering for 2 years now through this. It's time to let go. He needs to go. But he'd looked so well. It was just overwhelming, I think, for the family and for the members of staff who were looking after him. And we moved into a different room because he didn't actually need the resuscitation area anymore. And his family turned up. He woke up and he chatted to every single member of his family. And me and his wife stood back and were watching. And we both said it's almost like he's saying his goodbyes to all the different relatives that were there, and I went away, went back, and he was back asleep again and looked very peaceful. And I was being asked the question by lots of staff and members of the family, is this it? What are we going to do? And I guess the thing that I think would be helpful to discuss is, how do we tell when somebody is dying? How do we know? Do we ever know? Because you can diagnose a heart attack from an ECG, from a blood test, from a history, but it's not like that. It's not tangible when you're diagnosing somebody who's dying. There is no symptom list. There is no blood test. And I just felt like, I don't know, it was really hard, really challenging to make that call.
I think you're right, but when we talk about whether someone's dying or not, we move into a world of probabilities, and we find ourselves saying to relatives things like, they may rally, but I would not be surprised, based on my experience, if he passed away within the next hours or maybe short days after now. And I have been in every combination. I've brought families in and prepared them for the worst. The next day, the patient's sitting up eating cornflakes. They get discharged 2 days later, which is great. This is great. They've got some more time. But some families react funny to, you scared us. You scared the life out of us. We brought everybody in. My cousin flew over from Canada and he didn't die. They do expect a bit more exactitude than we're able to offer. I've been in cases where I've said, they've made a fantastic improvement today. Why don't you guys go home and get some sleep? We'll call you if there's any change. And an hour later, after they've left the hospital, the patient just slips away. They've come back and they said, and I picked up certain sort of cultural things about this. People have saying that patients often do suddenly perk up before they die. It sounds like what your guy did. They sometimes rally a little bit and they sit up and they have a cup of tea, and then they pass away soon after. It seems I think it's so common that people will sit with a dying relative in hospital for so long. When they go to get a coffee or a meal, or they go home to get changed, they die. And I've heard like nurses say, "Oh, it's very common. It's almost as like he didn't want to die in front of you. He wanted to do it on his own." These are sometimes they're quite twee things that we say, but they come from it happening frequently enough for it to be developed as a cultural stereotype. So, and you've heard this as well, this sort of thing.
Yeah, and that actual situation with this gentleman is, I actually did say that to the family, because there was and I did say, actually sometimes what happens is the family leaves and then people drift away peacefully and calmly when they've said their goodbyes. And it did seem like he perked up. He did say his goodbyes. He was, to his family, and then majority of the family left. His wife stayed and his mom stayed, and there was his son stayed, and there was a few people there. And it was about was he dying? Should I be stopping active treatment? So that was the question as well that the wife wanted answering. At the moment, you are treating the high potassium. We are treating for spontaneous bacterial peritonitis. We are treating the liver problems. I was giving him vitamin K for the high INR. So I was giving lots and lots of active treatment. He had lots of cannulas into him. And his wife said to me, is this the right thing to do? And I said, if I stop all of these treatments, the chances are that this will be a terminal event and that he won't survive. If we carry on with the treatment, he could survive a couple more days.
Yeah.
Maybe longer. But I don't know. I can't answer that question. And she was very clear that the family wanted, and he'd expressed wishes before, that he wanted a natural, dignified death. And that actually the invasive cannulas and all this, if it came to it, he didn't want anymore.
And if that's coming from the patient, that's a very clear signal, I guess.
Very powerful. Yeah.
I know what you mean. I remember sometimes when I'm treating patients who have very labile blood sugars, and I say, look, I think they're dying. We can stop doing blood sugars. But what if they get a hypo like they did yesterday, 1.1? We could give them a bit of dextrose and they might wake up and have a cup of tea. And then it's like, oh, I guess you're right. Well, I guess we could stop doing OBS except for blood sugars, but that seems weird. Why would I check blood sugars on someone else was dying? And it can be hard to get the path right, because they're complicated paths. And I often phrase it to families as, I'm gonna refocus my treatment. I'm gonna treat them actively, but I'm gonna treat their symptoms, and I'm not going to treat what I think is driving the symptoms, because I don't think it's going to buy them any time or any good time, and I don't think it will change the outcome of this admission. And I think that's a very honest thing to say, and see how people take that on board. Some people find that intolerable. Some people find that absolutely the right thing to do. So you have to have, it takes a lot of time, and you have to keep having conversations over and over.
Mm.
People forget things, they don't take things in the stress of the moment. The other half
Absolutely.
of the family all turn up and they need a doctor's, they want to know as well, and they might disagree with the first bit of the family. It's very, very time intensive.
Mm.
But there's no real way around it. And sometimes the patient will give you strong signals they are dying. They will drop their GCS. They will get that rattle. They will stop interacting. And then you can say, I think we're looking at
Yeah.
hours rather than days here. But sometimes they stay alert. We have the care plan here, the excellence care plan for people at the end of life. And it's a care plan. I'm always drilling into people. People say, oh, are they on the care pathway? I'm like, no, no, no. It's not a pathway. A pathway indicates there is a set course. I'm going to force this patient down with a set destination. It's a care plan, and it's responsive to the patient. Just be careful with our language. People have long memories, and people remember the Liverpool care plan. So
Mm.
say the care. So, and that usually means don't do bloods because it's painful. And I have put people within the framework of the care plan, and then taken them off it a few days later when they've perked up. But I said, okay,
Mhm.
you don't need. Let's do a blood test today,
Yeah.
and see what the bloods are looking like. Within recent memory, I had a patient who I said to the family, I don't see her going home. I think she will die this admission. I'm duty bound to be honest with you, prepare you for this. Hope you understand that. And we're not going to do any more blood tests. After 4 days with the patient sort of sitting there chatting and eating, I was like, I wonder if she is dying after all. I'm going to do a blood test today, which is outside, what you would normally do for someone who we said, let's just treat them symptomatically. Did a blood test. Her sodium was like 191. I was like, oh, okay, no, I think she is dying. And that was a useful biochemical marker. Just to be clear, hypernatremia does not diagnose dying, but as with all the other information in that particular case, that was a really useful marker that she had lost sodium homeostasis, which you do see in terminally frail patients. And I went, okay, no, it is right. No more blood tests after now. I feel more certain that we're in the right pathway. So I think the most important thing to say, it is not one size fits all. If you think someone is or could be dying, you have to see them on a day-by-day basis, be able to keep your mind open and challenge your previous assumptions, and maybe reflect and
Mm.
re-diagnose people if they're not following a certain pathway you thought they would. And
Mm.
be able to go back to the drawing board and say, well, look, why do we do things a bit differently today? Because they're taking a slightly different path as to one I want.
Mm.
And I'm honest with patients when they say, how long? I say doctors are notoriously bad at predicting
Yeah.
this. I said, your father, your husband, whoever it is, they will do things in their own time. They will do things in their own time, and I don't know what that will be. All I can say is I think the end point will be this. I don't see them surviving, and I want to
Mhm.
be honest with you and tell you that. And I think whatever it's days, whenever it's hours, we just make sure they are as comfortable and as happy as we can make them, and that is good palliative care.
Mm. Yeah. And I mean, it was what was really challenging about this case is we were trying to do all of this in a very busy ED department, and it didn't feel like the right environment for the family and the patient. To be honest, it was very noisy. It's just chaotic.
Yeah.
And we got him into we just moved him out of resus, as I say, he didn't need it anymore, and the family were there. And one of the nurses come up to me. I'd had a conversation with the relatives, and we were in agreement that actually stopping the treatment for the hyperkalemia and the sepsis was the right thing to do.
Mm-hmm.
And they were very clear that they wanted to allow, and this was going along with the patient's wishes, a natural, dignified, peaceful death.
Yeah.
And that's what they wanted to happen. So we'd had this conversation, and I had stopped the medication that we'd been giving him. And I had prescribed anticipatory medications if required. So I'd prescribed some morphine, some midazolam, some hyoscine in case, he was in distress. And I stopped these. We stopped the active treatment, and he had these periods of lucidity and chatting and then drifting away. And nurses were wandering past who were looking after him saying, he's not dying, you've got it wrong. look at him, he's sitting up, he's chatting. You've just stopped all his treatment. Do you think that was the right thing to do? And I was like, oh God, I don't know if this is the right thing to do, but it feels like it was the right thing to do. The family were on board. And that was another challenge as to how to manage the expectations of the members of staff as well. Because it's very hard to also nurse a patient who is at the end of their life, particularly because they didn't think that it was the right thing to do. So it really highlighted the importance of communicating the decision to the family, but also having an open, honest conversation with the nursing staff and explaining why I'd made the decisions and why I was doing what I was doing.
Well, it was great that you have this relationship with your nursing colleagues. They're able to come and say things like that they're able to approach you and say, are you sure? But then, of course, the downside of that is you have to be firm in your convictions. I mean, it's fine for people to double check. If people are approaching you in a professional manner and saying, I wonder if this is the right thing to do because I've noticed this, that could be really useful information if you are the senior decision maker for that patient. And sometimes the answer is, I appreciate that. That was part of my decision making. I see where you're coming from. However, we're going to do this, and I think this is the right thing to do. And that's part of the progression through training, isn't it? And developing your skills as a senior physician, as a consultant, and being able to make your decisions and then be convicted enough to stand by them whilst remaining open to other people's perspectives.
Yeah, absolutely. I completely agree. It was, and the story with this gentleman is that we did take down all of the medication that we'd been prescribed. He was moved to a different area, a lot quieter, on our admissions unit, and he passed away that evening very peacefully.
Sounds like
with his family around. So it was, we did the right thing at the right time, and he was in the right place. And his family, I went to the family, it was about 9 o'clock in the evening, had been moved down, and he was incredibly peaceful, and his family were very happy with the decisions that had been made. Again, I think it was what was really interesting about these two cases is that they were basically same location, seen one after another. And both of them, I felt like I was being asked to make a very difficult decision about, are they dying or not? And obviously it's not binary. It's not a yes or no decision. And then it made me think about, are we trained to diagnose a dying patient? I don't think we are at medical school. And unfortunately, on the day in question, we didn't have many people from the palliative care team around to help. It was just one of those days when people were on annual leave and things like that. So I didn't have that support because they weren't around. And that was a challenge.
I don't think we are. Well, no, we're definitely not trained to diagnose dying. And I think that probably reflects as it's, I mean, maybe somebody would even challenge it's a diagnosis. I don't know. I think
is it a natural
part
of life?
Exactly. In the same, you don't diagnose birth. I don't know. I think probably it's probably not taught because it's not teachable, or it's not appropriate for teaching, and it's something you pick up as part of your clinical experience. I think compared to when you and I were training to now, there is a much heavier emphasis on good palliative care in general medical curricula than before, which is a really good thing. For example, I know in the IMT, internal medicine training curriculum, they have a whole section on managing end-of-life care and applying palliative care skills, which I certainly can say was not there when I was a trainee. And the fact that it's come to the forefront, that it's a branch of medicine, it's a skill that every generalist should have, I think is really, really good. And I think part of that is recognizing people who could be dying and giving the right treatments for it. But the clinical diagnosis of dying, I think, is elusive and probably not teachable. But I'm very keen to be corrected or educated on this by anyone who's listening who wants to reach out.
Yeah, I completely agree. I don't know what the answer is. I don't know what's right or wrong. I don't know whether I did the right or wrong things that day. What I do know is that I felt like there were two cases that I was outside my comfort zone. You often feel as a consultant, you've dealt with lots of different things, you manage lots of different situations, but for some reason, these two cases made me feel uncomfortable. I felt like I just feel like I wasn't managing them as well as I could be, to be honest. So definitely some reflective points about discussion with family, discussion with all the staff involved as well. I think the key thing, again, that always comes out in these cases is communication and the importance of communicating with friends, family, other staff. and I did ask colleagues as well within the emergency department and just download what I was thinking and say, am I doing the right thing? Is this the right thing to do? Am I missing something? Am I, and that was really helpful, is having that second opinion.
Yeah, none of us work in a vacuum. There's people that we can ask for. People, when you are a trainee, you can ask a senior doctor, but who do you ask of your consultant? Well, there's other one that we ask each other.
Yeah, absolutely.
Yeah.
And I think the more senior I get as a consultant, or not more senior, but the more years I do as a consultant, I'm much more open to asking for help. Whereas when I first started as a consultant, I was like, well, I'm a consultant now, I should know how to do everything. But now I'm like, can I have some help, please? I'm really struggling. So I'm much more open to getting second opinions and third opinions and just asking for help.
Yeah, I think that's good practice.
Yeah. Fab. I mean, I think we've generated probably lots of discussion points, and I think the discussion on this area could go on for a long time, to be honest. But I feel comfortable at the end of the day that both patients got the right care at the right time, in the right place, with good, appropriate communication was done.
More than that.
Yeah, we did our best. And I think that's the key thing, is that as long as you do your best for every patient that you see on your resources that day, we can't ask any more of ourselves and those we work with.
Exactly. I agree.
Anything else you'd like to say, Ben, before we close this podcast?
No, thank you once again for your viscerally honest stories and your reactions. I think these are useful to hear, that people hear us questioning ourselves and how we think and how we reflect. I think this is all really useful stuff. So hopefully people got as much out of it as we do talking to each other.
Yeah, absolutely. Thank you so much to everybody for listening to the Home of Medicine podcast, and we'll be back soon. Thanks for listening. Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.